Are we okay?
Yes, please.
Okay. Class captain, have you ever had the chance to reconstitute or direct somebody, a nurse or a clinician, to reconstitute an artesunate injection, be it for IV or IM? Class captain,
Yes, please. I have
you
constituted.
had the chance. Okay. So the current artesunate in the system, based on either you are going per IV or IM, you have different concentrations that you are going to prepare. Okay. Class captain, for the IV artesunate, what is your target concentration as in the dilution for IV? If you are
Doesn't
directing
it
somebody,
depend on the because there's 60 and then there's 120.
it doesn't depend on the strength. It depends on the route. So per the route, we have to either IM or IV. And the question is, for IV, what concentration do you prepare or do you advise them to prepare? In fact, this is supposed to be our job. No nurse nor doctor should reconstitute or dilute any drug. But because of our numbers in the hospital, we have left this vital duty of ours to the clinicians and the nurses to do. And this constitutes a very important aspect of medication error. Reconstitutions and dilution errors. It's massive. Just because our numbers are few and we are not doing the job. It's not our fault. It's the numbers. Class captain, so what is the target? IV, artesunate.
Please, sir, for IV is 10 milligram per ml.
IV is 10 milligram per ml. Okay. So let's learn from first principles. If you have the 30 milligram vial of artesunate, understand there is 30, there is 60, there is 120, like here. How does it come? The package. What and what do you have in artesunate pack? Injectable. Class captain.
Please, sir, you have sodium bicarbonate and then 0.9 normal saline.
And then the artesunate as part of the whole pack. So what is the role of the sodium bicarbonate and normal saline? What role are these two? As for the artesunate, we know is the active ingredient, the one going to do the job. Why bicarbonate? Why normal saline?
Hello, sir.
Yeah, hello.
The artesunate powder in the pack comes as artesonic acid. So when you add the sodium bicarbonate to it, it neutralizes it and forms a salt which will be soluble in the normal saline.
So they are trying to utilize the basic principle in chemistry. All sodium salts are soluble in water. Thank you very much. So that is the rule of the bicarbonate, and it normally comes as sodium bicarbonate. The powder is artesonic acid. You add an acid to any sodium-containing base, you form a sodium salt. By basic principles, all sodium salt will be soluble in water. We want it to be soluble because we are going to use it as an injectable. We cannot inject any precipitated solution. We are going to create problems. And therefore, that is the rule of sodium bicarbonate. I know you know this already. It's just something to refresh you. Then you use the normal saline for dilution to achieve your target concentration that you want to prepare. As your colleague said, for IV, we are targeting 10 milligram per ml. after you've added your sodium bicarbonate and you have achieved your sodium artesunate, you have to add the normal saline as the diluent to be able to achieve your targeted concentration. So, for example, if you are learning from first principles, you are using 30 milligram val artesunate. That comes with 0.5 mils of sodium bicarbonate. As for the saline, let's even forget about the volume. You can even have 500 mils, 1,000 mils, or whatever. Apart from the one in the pack, you always have normal saline at the pharmacy. So you have unlimited amount. We are going to use that one as our diluent if we are even forgetting about the one in the pack. So the main thing is that you first have to create the sodium salt. That is a caution. If you don't create the sodium salt first and you add normal saline is a polar solvent that tersonic acid will precipitate. So never skip first the addition of bicarbonate to that tersonic acid and straight away adding your normal saline. You've messed up big time. So tersonic acid is not soluble in polar solvents like normal saline. First, create the sodium salt. So the first step is the addition of your sodium bicarbonate, which will be 0.5 ml for the 30 milligram val pack. You add it, that tersonic acid will go into solution. Then you form a very clear solution, which will be sodium artesunate. Sodium artesunate, 30 milligram in 0.5 mils because it went into solution. It will not increase the volume. You will have 0.5 ml now containing 30 milligram sodium artesunate. Now, how do we get our 10 milligram per ml? Now we have 30 milligram per 0.5 mils. So how are we going to get a solution that now contains, or if you pick each ml, it will contain 30 milligram. So the strategy is to try and then make it such that the volume becomes 3 ml because the active ingredient in there is 30 milligram. So if you are to push it to 3 mils, then 30 divided by 3 will be 10. So each ml will now contain 10 milligram. So if you already have 0.5 mils containing 30, how much of the diluent do you need to increase the volume from 0.5 to 3 mil? Obviously, that will be 2.5 mils. So you add 2.5 mils of your polar solvent provided, which is now normal saline, to the 0.5 mil containing the 30 milligram sodium artesunate. You shake it, the final volume becomes 3 mils solution, still containing the 30 milligram. You've not added any other artesunate. It is still the 30 milligram in there. So the final concentration now is 30 milligram per 3 mil. If you are to divide through by 3, the denominator becomes 1 mil. The numerator becomes 10 milligrams. So which means you have achieved your target of producing a diluted artesunate solution, which is 10 milligram per mil, the concentration recommended for IV administration. Now, once you know this, the rest is just multiplying by a factor. For example, after knowing the various quantities of the various agents for the 30 milligram bar, how do you change 30 milligram to 60? When you multiply 30 by 2, you get 60. When you multiply 30 by 4, you get 120. So if you are having a 60 milligram bar, use a factor of 2 and multiply through each component by 222. So 30 times 2 is 60 milligram, which means the bicarbonate quantity for the 60 milligram will also be 0.5 times 2, which will be 1 mil. Class captain, can you see? Can you see 1 mil here?
Yes, please.
All right. So you are multiplying through the various components here by a factor of 2, since 30 times 2 is 60. So 0.5 times 2 will give you 1 mil. Likewise, the 2.5 times 2 giving you 5 mils. If you are using a 120 milligram vial, moving from 30 to 120 is by multiplying it by 4. So 30 times 4 is 120. 0.5 mil times 4 is 2 mils. Then 2.4 mils times 4 will be 10 mils. It is always good to learn from first principles so that you apply it as you move. So depending on the patient weight, the dose will change. And that will determine which of the valves you use and even the number of valves that you are going to use. This is what you do for an IV target. 10 milligram per mil is your target. If you are going by IM, then the scenario changes. And since per IM, you cannot give high volumes. Per IM, you can't give high volumes. You can't give more than 20 mil. No drag. If you are going by IM, the highest volume that you can give is 20 mils. You don't load somebody's buttocks muscles with so much volumes. So to be able to do that, you need to concentrate the solution so that the final volume will not be that high. So for IM, we are concentrating the solution. So we change the concentrate from 10 milligram per mil to 20 milligram per mil. The higher the concentration, the smaller the volume. So for IV, it is 10 milligram per mil. For IM, we are doing 20 milligram per mil. Why? Because we can't give large volumes per IM. And therefore, the strategy is to give a concentrated solution to minimize the volume. How do you go by it? Similar principle. Let's start from first line. We are still trying to learn with 30 milligram vial. It still comes with 0.5 mil of bicarbonate. So you first form the sodium salt by adding the bicarbonate to that tersonic acid. You shake it very well. It will go into solution. You get your 30 milligram per 0.5 mils. Now, the target is to get each mil containing 20 milligram. So what do? You dilute the resulting solution with 1 mil of your diluent, and the final volume becomes 1.5 mils containing 30 milligram of your active agent. 1 mil being added to the 0.5 mil becomes 1.5 mil, but the active ingredient will be the same, 30. If you want to test whether you've achieved your concentration, now by simple proportion, each 1.5 mil, which is the final volume, contains 30 milligram. So 1 mil will contain how much? So 1 over 1.5 times 30, and that will give you 20. So it means that you have achieved your target of 20 milligram per mil. So with this, the final volume becomes 1.5. Active ingredients in there by using the 30 milligram bar is still 30 milligram. If you do simple proportion, you realize that you will get 20 milligram per each mil. That is the final concentration. And this is what is recommended for IM because we want to reduce the volume. We can't give huge volumes. Same as we did earlier. If you are handling a 60 milligram vial, a factor of 2, you multiply all through. So 0.5 times 2, you get 1. Then 1 mil times 2, you get 2. If you are doing the 120, it is times 4. So 4 times 1 mil will give you 4 mil. 0.5 times 4 will give you 2 mil. 30 milligram times 4 is 120. So that is the targeted concentration for IM administration at tersonate. IV is 10 milligram per mil. That one, you have the luxury to do huge volumes if you are using IV, and therefore you are free to reduce the concentration. It doesn't matter the volume that you get. You are introducing it into the blood, so you can give high volumes. For IM, you can't give huge volumes. So concentrate it and make it twice the strength of the one for IV, 20 milligram per mil. Class captain, are you okay?
Yes, please.
Hello. All right. So now, fortunately, currently, the producers of artesunate are trying to roll onto the market a new artesunate injectable, and that one is called Agison. Agison. Why do we have the one that we've been discussing, yet they want to introduce another artesunate pack? It means the new one should have certain advantages over the existing one. So let's look at the two. Some hospitals have even started using the new ones. So in terms of composition, what is the difference between the existing one and then the incoming one? So in terms of composition, as Bernard or the guy said, it contains artesunate acid. In a different bottle, we have the sodium bicarb. In a different bottle, we have our diluent, normal saline. So you have three separate things packed in one. So it is a 3-in-1 pack. Artesunate acid, sodium bicarb, and normal saline. In the new pack, we have artesunate acid, separate pack. We have sodium bicarb. No, we have the artesunate acid combined, separate pack. Then the sodium and arginic acid, which is arginine, combined together. So you have the artesunate acid separate. You have sodium bicarbonate and arginine in one pack. So we have 3 separate bottles in the old one, each holding the 3 separate ingredients in the old pack. Whilst in the new pack, we have just two separate bottles. One of them contains the active ingredient, artesunate acid. The other contains a combination of sodium bicarbonate and arginine, 2 packs. Now, what happens when you are doing the reconstitution? For the old pack, you realize you first have to do the sodium artesunate, that is step 1, before you dilute it to the required concentration. So 2 steps. 2 steps for the old pack. The new pack, since you have just 2, it's just 1 step. So you just add the artesunate acid and the other bottle containing the 2 agents, sodium bicarb and arginine. So it's just a 1-step step. You add everything once and you are done. You don't need any third or any second step. Now, for the first one, the existing one, you realize you have different concentration to be prepared based on the route of administration. If you are going per IV, you are doing 10 milligrams per ml. If you are going per IM, you are doing 20. This can create confusion. It can create confusion. So the advantage here is that with the new one, be it IV or IM, it doesn't matter. You are targeting the same concentration, and that is 20 milligrams per ml. So you don't need to be sure that, hey, am I doing IM or IV? Which concentration should I do or should I prepare? With the new one, all routes, same concentration to prepare, 20 milligrams per ml. Unlike the old one or the existing one that you have to be sure. If you are doing IV, you have to know that you are preparing 10 milligrams per ml. And if you are doing IM, you have to know that you are preparing 20. You can mix it and exchange the concentrations and get it all wrong. Also, with a new one, since you are doing just 1 step, reconstitution time is very quick. 1 minute and you are done. You just mix it and you are done. With the old one, you need about 3 to 4 minutes to shake it very well and to dilute everything before you are done. So time for the reconstitution for the old one or the existing one is longer as compared to the new one, which is just 1 step. In terms of volume, how much volume? Remember, the amount or the concentration to be prepared will dictate the final volume. So if the concentration is different as per the route, then of course, the volume too will be different as per the route. So it means that for the old one, if, for example, you are preparing for somebody who is 25 kg, very soon we will look at the doses and number of vials that you use, and then even the volumes that is required as per the patient weight. It means you are doing IV 6 mils and IM 3 mils. Confusion. Since for the new one, we are going by just one concentration, the volume is always the same. So you don't need to be thinking and be cross-checking, being sure whether IV or IM, the final volume is always the same. For example, for a 25 kg, you can prepare just one concentration, 3 mil, because the one volume, 3 mil, because the concentration is always 20 milligram per mil. So we hope that they will rule in this type of agent, that is the Addison, for us to be okay and not to be worried about which concentration to be prepared based on the IV IM. We always get it right. It's easy. Dealing with one thing is always easy with dealing with two things. Two things, is it this or that? You make a mistake and you are done. Class captain, any issues? Any issues? So note that there is also another formulation called Addison. Addison is coined from arginine and artesunate. So Argison, A-R-G-I and then S-U-N, Argison. And that contains artesonic acid in one bottle and a combination of sodium bicarb and arginine in another bottle. And that gives us the chance for a one-step reconstitution, a single concentration for both routes, either IV or IM. Very short time for the preparation, and therefore just always a single volume needed because of the single concentration. Can we continue?
Yes, please.
All right. So now.
Hello, sir.
Yeah, hello.
Sir, I'm sorry to bother you, but I think I would like you to go through the reconstitution calculation again. I'm confused there.
For which one?
I kind of get a concept, but as to how you were able to get to the final concentrations for the IM and IV, which is 10 milligram per mil and 20 milligram, I'm still confused.
Why are you confused? Which aspect? Is it
I think it has to do with where we added the 0.5 and the 1 to the 0.5 to make a 0.5. Then later made some calculations there, and then we got to proving why it's 10 milligram, 20 milligram per mil.
All right. So the 0.5 always come with a pack. The 0.5 mil bicarbonate always come with a pack. Once it is the 30 milligram vial you are dealing with, you are always provided with 0.5 mils of bicarbonate. And we said artesunate or artesonic acid is insoluble in polar solvents, like normal saline. And therefore, the first step is to create a sodium salt of the artesonic acid, which by the basic principles, solubility principles, chemistry, we say that all sodium salts, all potassium salts are soluble in water. So we are taking that as an advantage by adding something that can introduce sodium to the artesunate, sodium bicarbonate, a base reacting with artesonic acid, an acid. At the end of the day, we produce sodium artesunate. So that will go into solution. The solution will be clear after shaking it. So you have, for example, 30 milligram. If you are dealing with IM administration, you have 0.5 mils that has solubilized the artesonic acid. So it has gone into solution. So 30 milligram in 0.5 mil of the bicarbonate provided. So that is the first step. Now, when you are done, we are saying that for the existing artesunate injections, based on the route that you want to go, either IM or IV, you have to prepare different concentrations. For the IV, you are doing 10 milligram per mil. For the IM, since we can't give large volumes, then we need to concentrate the solution so that the volume will be reduced. So we are doing 20 milligram per mil. Now, at this point, we have 0.5 mils containing 30 milligram. of the active ingredient. How do we manipulate this so that at the end of the day, the final solution, the diluted solution that we are going to prepare, when we pick each meal from the final diluted solution, each meal will contain 20 milligrams of artesunate for IM administration. If it is for IV administration, after this point of having the 0.5 ml containing 30 milligrams solution, how do we manipulate that one too? By adding or diluting it with the normal saline, such that at the end of the day, when we pick each meal of the one that we are going to use for IV, we will get each 1 ml containing 10 milligrams. So that is the problem. After you have done the reconstitution, you are now going to dilute it. So now we have achieved our target of not creating precipitated solution by adding the bicarb to the artesunate. How do we now get our second target? That is the required concentration for either IV or IM. And we are saying that, for example, for IM, since we know our target concentration, that we are supposed to get 20 milligrams per each meal. And we know where we are starting from. 20, we have 30 milligrams. If we are using the 30 milligram vial, we have 30 milligrams, which is now in 0.5 mils. So from your mass, this is mass. How much of the normal saline do you think we should add to what volume? Noting that we already have 0.5 mils containing 30. How much of the normal saline would you recommend that we should add to the existing 0.5 ml containing 30 milligrams? So that at the end of the day, each ml of the final diluted solution will contain 20 milligrams for IM administration. Or if you want to go per IV, how much of the normal saline should we add to the current 0.5 mils containing 30 milligrams? So that at the end of the day, when we pick each meal, that one will contain 10 milligrams per meal. So 10 milligrams per meal for IV, 20 milligrams per meal for IM. Now, for each of them, we are at 0.5 mils containing 30. So from here, it is mass. So what would you suggest? Let's say if you are dealing with the IM route, your target is 20 milligrams per meal, but you are now at 0.5 mil containing 30 milligrams. Please, the one who asked the question. Hello? Hello?
Hello, sir.
Yeah. So what do you think? Do you remember your V1 C1 is equal to V2 C2?
Yes, sir.
Can you apply that for a better understanding? Because you know your target, the concentration. You know your starting concentration. So you know your C2, you know your C1. You know your V1 to be 0.5 mils. Your C1 is 30 milligrams per 0.5. And then your C2 is that. So you can convert those concentration to 100% or percentage terms. So when you get the percentages, then you fix it in the formula. V1C1 is equal to V2C. Are you okay? Or .5 mils. And you want your final concentration to be 10 milligrams per mil. What do you do if it's for IV administration? You only raise the volume to 3 mils so that it will now be 30 milligrams containing 3 mils. Then if you pick each mil, it will contain 10 milligrams for IV administration. Are you okay?
Yes, sir.
All right. Okay. Back Captain, any further questions?
No, please.
All right. So now, Depending on the person's weight, artesunate injection is dosed according to weight. So you need to know, because you'll be dealing with vials containing the artesonic acid. So how many of the vials, whether it is the 30 milligram that you have, or the 60 or the 120, depending on the weight of the patient. How do you know the amount of vials that you need? Because you don't need to be wasting a lot of ingredients. Mind you, for artesunate IV, after the reconstitution, it can only be stored for just 1 hour. After 1 hour, the excess should be discarded. So if you don't have any other patients that you can give the remainder, then you are going to waste if you over-prepare. And therefore, you need to prepare the things such that you don't waste so much of the drug. So based on the weight of the patient, you can calculate almost the amount of vials that you would need for that particular patient. So for example, if let's say you have a patient weighing 70 kg, there is a formula for the calculation for the number of vials for that patient. And this is the formula. So the numerator is the weight of the patient times the dose. So for an adult patient who is more than 20 kg and 70 kg, the weight, you put 70 here, then the dose is 2.4. So 2.4 times the weight divided by the strength of the vial available. The strength of the vial available. So the weight of the patient times the dose divided by the strength of the vial available will give you the number of vials that you need for that patient. So that if you are dealing with a 30 or 60 or 120, you know that this patient, I'm going to use this number of vials. Unfortunately, in most cases, you are going to get decimals. So let's say you do the calculation for the 30 milligram vial and you get 3.6 vials. As for the 3 vials, you can get, but you can't get 0.6 vials. So in that case, what you do is to pick his 4 vials. Picking 4 vials also means that you are preparing in excess, and therefore the patient doesn't need all the total amount that you prepare. I repeat, you fix the values in this formula. If you get a round figure, 1 vial, 2 vials, 3 vials, then you are happy. That one you prepare and you know that that is exactly the amount that the patient needs. So you inject that. But if you do your calculation and you get, say, 3.5 vials, there is no 0.5 vials. So what you do is to prepare in excess by using 4 vials, meaning you are preparing in excess and you can't give the whole volume, the whole amount to the patient. That will be an overdose. So after you have used this formula to calculate for the number of vials and you get a decimal, you take the next highest whole number as the number of vials. It means that you have prepared in excess. If you are to give that whole amount to the patient, you are giving an overdose. So with that, after your preparation, as per these recommendations, the dilutions. So each vial, let's say you use 4 vials for somebody who needs 3.5 vials. So in each vial, in each of the 30 milligram vial, you will take each vial through this process. So you get 3 or 4 different diluted solutions. And the patient will need some amount from there because you prepared more than what the patient needs. So how do you know how much in terms of volume to pick from the total that you have prepared, since you have prepared in excess? That one too, you can use this formula. Volume required is equal to same numerator as the vials, the weight of the patient times the dose. But in this case, per the route that you are going, if it is iron, for iron, we said the concentration is 20 milligram per ml. You put 20 there. If it is IV, it's supposed to be 10 milligram per ml. Then you put 10 there. So the volume that the patient required, the numerator will not change. from the formula that you use for the valve calculation. But the denominator now will switch from the strength of the valve to the concentration as per the route of administration. So if it is IM, you put 20 here. If it is IV, you put 10 here. And then that will help you to calculate for the volume that you need from the excess that you have prepared. You pick it into a huge syringe, you put your needle on top, then you administer it per IV or per IM. Slow administration. And by slow, I mean every minute you push in 3 to 4 mils. Every minute you push in 3 to 4 mils. So you can calculate for the number of valves that you need because you don't want to waste so much. It can only be stored for just 1 hour, after which it should be discarded. So wasting so much ingredients, it means you are causing harm to the patient, cost burden for the patient. You do the calculation to know the amount of valves. If it is a round figure, then you are giving everything to the patient. If it becomes a decimal, you always prepare in excess. You choose the next highest whole number. Even if it is 4.1 valves, don't do 4 valves. If you do 4 valves, it means you are preparing underdose and you are going to give underdose. So even if it is 4.1 valves, you are doing 5 valves, meaning you have also prepared in excess of 0.9 valves. Do it individually in the valves. Do your calculation for the required volume by using the concentration recommended as per the route of administration. Get your final volume and administer it by slow IV or IM, which is 3 to 4 mils per minute. Class captain, are we okay?
Yes, please.
All right. Any questions? If not, we are switching to artemeter injection. So artemeter is IM. Obviously, it's an oily preparation, and therefore you cannot administer it per IV. It may clog the blood vessel and cause issues. Recommended dose is 3.2 milligrams stat. This is the main drug we've been abusing for uncomplicated malaria. They always start with the 3.2 milligram IM stat for uncomplicated malaria, and the policy doesn't recommend that. In fact, they specifically state that we should not do any injection in uncomplicated malaria. If you do this, it is once a day. If the patient gets better, then subsequently you switch to the full course. Please, let me remind you, for the artesunate, as I said, you are doing for time 0, time 12 hours from the start. Then you do the third dose 24 hours away from the start dose. So that is the initial dose that you give. 3 doses compulsory. You can't skip one. You think that you have given the first dose and the patient is getting better, so you are switching. No. Whether the patient gets better or not, the first 3 doses within the first 24 hours is mandatory. For artemeter, we are lucky. It's just 1 daily dose. So once you give your 3.2 milligram and the patient gets better, the next day you switch to the artemisinin-based oral therapies. If the patient doesn't get better, you reduce the dose to half, which is 1.6 milligram daily for 4 additional days for artemeter, making a total of 5 days. For artemeter injection, 3.2 milligram per the patient's body weight start. The patient get better, switch to the full course, oral artemisinin base. If the patient doesn't get better, maintain the injection, but reduce to half the loading dose once daily for 4 additional days, making a total of 5 days. For artesunate, in case the patient doesn't get better after the first 3 doses, which is the 24 hours, maintain same dose. Don't reduce to half the dose. Maintain same dose. If it's an adult above or at 20 kg, 2.4. Below 20 kg, 3.0. Maintain it once daily for 6 additional days artesunate, making a total of 7 days. 7 days. For artemether, after the first dose, 24 hours time, reduce to half that dose. Do 4 more days in case the patient doesn't get better. So the total treatment duration for artemether is 5 days. Total treatment duration for artesunate is 7 days. That is, in both cases, if the patient doesn't get better and therefore cannot tolerate. If the patient can tolerate, you switch to the oral forms. You can only keep artesunate diluted solution for just 1 hour. Discard. So, and of course, if you give at time 0, your next dose is at 12 hours time. So there is no way you can use the one that you have prepared for the first dose, any remaining part for the second dose. No. Whether you want to store in the refrigerator or whatever, no way. Discard the excess because you can't use it after 12 hours. So for artesunate, you are going to discard.
Hello, sir. Please, I have a question.
Know the drugs. You need to advise. Past Captain, any issues?
Hello, sir. Please, can you go over the artemether? My network was breaking then.
So artemether, you give a loading dose of 3.2 milligrams. And remember, it is only iron. It is only iron. Why? Because it is oily and you can't administer an oily preparation per IV. You are going to block the blood vessel. So a loading dose of 3.2 milligrams per kg. That is for the first 24 hours. It's a once daily dose. If the patient gets better and can now tolerate oral, switch to a full course of the oral artemisinin-based therapies, the recommended ones. Artemether, lumefantrine, artesunate, amodiaquine. Currently, if the patient is not pregnant, artesunate pyrrolizine is also recommended. These 3 are all first-line recommendations. Second-line option is dihydroartemisinin, piperacin can also be used. But if the patient doesn't get better and therefore cannot tolerate oral, you are going to continue with the iron injection. So 24 hours after the loading dose of 3 point. Yeah, hello?
Yes, sir, please, so after, please, can you hear me?
It's better now.
Sir, please, so after you've given the maximum of 5 days or for the 7 days for any of the either artemether or artesunate, do you still continue with the orals, or that is it if the patient
No. If you do the full treatment course and the patient is okay, you don't have any issues with malaria anymore, you've done the test to confirm and then you have 0 isolate, you don't need to continue. So for artemether, if you do the 5 days, you are done, provided the patient will be cured. For artesunate, if you do the 7 days, you are done. But if you do the full course and the patient is still having issues with malaria, that is when you go by that recommendation, artesunate IV plus quinine IV. Are you okay?
Yes, please, sir. Thank you.
All right. Any other question? Okay, so now let's go to the 4th and the 5th on the hierarchy. That is quinine. Quinine. So quinine, the dose is always the same for all age groups, for all routes of administration, oral, IV, IM. Pediatrics, adult is always 10 milligram per kilogram body weight, 8 hourly. 10 milligram per kilogram body weight, 8 hourly for 7 days. That is if you want to go all the way out, it is also for 7 days. But for the injections, depending on the route that you are going, there are issues that you need to also learn. Quinine is a secretagogue. I mentioned that. Quinine is a secretagogue which can influence insulin secretion and therefore can contribute to hypoglycemia. If you are giving it per IV or per IM, there is always one strong warning. This time I would say is a warning, not even a caution. There is always one strong warning with quinine. Never give quinine injectable undiluted. I repeat, never give quinine injectable, be it IV or IM, undiluted. Why? Because it will cause severe hypotension and the patient may die. Hypo, a reduction in BP, not hyper. Hypo, reduce BP. If you give quinine undiluted, it happens. In Confanoche, some 15 years ago, there was a case like that. A student nurse, the in charge gave the quinine injection. The in charge had put the thing into the syringe with a needle on top, about to dilute, and he had to attend to another emergency case. So he gave the injection in the syringe to the student nurse that he should hold it. She's coming. Only for the student nurse to inject the undiluted quinine to a pediatric. Suddenly, the child died on the mom's laps. It happens. Severe hypotension. So be it IV or IM, you are going to dilute. For IM, you are allowed to dilute with either normal saline or a dextrose-containing agent. That would even be better because of its potential hypoglycemic issues if you are using a dextrose-containing agent for the IV. So, as I said, the dose is always 10 milligram per kilogram body weight. Cutoff point is 600. If you calculate and you get more than 600, the patient cannot take more than 600. And it is every 8 hours. In the recommended diluent, 5 to 10 mils. So in order not to confuse yourself, you can focus on 10. So the dose is 10. The amount of the diluent is also 10. So 10 mil per kg of the dextrose. So if, let's say, the patient is 60 kg, and therefore per the calculation, you are using 600 milligram, it means you can do 600 mils of the dextrose, but it is between 5 to 10, which means you can also give 500. So you just push the 600 milligram into a 500 milligram over, say, 4 to 8 hours. Because every 8 hours you repeat. Every 8 hours you repeat. So that is the dilution. 5 to 10 ml per kg of the diluent. Yeah, hello? Yeah, hello?
Please, your line is breaking.
Sorry. Is it better now?
Yes, please.
Okay, so I'm saying that you calculate the dose. You also need to calculate the amount of the diluent that you use. To make it easy for you, since the dose is 10 milligram, you can always remember the diluent as also 10. But note that it is between 5 to 10 mils per kg. That's recommended. So for example, for a 60 kg patient, if you calculate and you get 600 milligram, it means 60 kg times 10 mil is also 600 mil. But note that it is between 5 to 10. So it means you can go back and use 500 mils, which falls within 5 to 10 mils. So you just pull your 2 mils of quinine sulfate or quinine HCl. Normally it is 1 mil equal to 300 milligram, and it comes as a 2 mil ampoule. So the 2 mil normally contains 600 milligram. So you pull all the 2 mils containing the 600 milligram that a 60 kg patient needs, and you push it into 500 mils normal saline or dextrose saline or 5% saline. In fact, this is recommended because of the possible hypoglycemic potential of quinine. You push it in there. You run the infusion over 4 to 8 hours. Remember that the frequency is 8 hourly. So by the time the first dose is about finishing, then you are getting ready to introduce the second dose every 8 hours. If you are to continue, then that would be a total of 7 days. If you are to continue on, that would be a total of 7 days. So that is what you do for the IV administration. Never give quinine undiluted because of high risk of hypotension. Always note the usual side effect of quinine, synchronism. So tinnitus and all those things, those ringing bells in your ears and what have you, that is the main problem, together with hypoglycemia. Some people also report that they feel very weak. For the IM, that is where we have issues with the calculation. As pharmacists, that is our job. So for the IM, there is a little bit of confusion here. IM means you are going to inject into muscles. Never do any diluent that contains dextrose for IM because dextrose is acidic. If you introduce it into the muscle, it will burn the muscle. So for IM quinine, you are not using any dextrose containing agent. You are using normal saline or worst case scenario, water for injection. What normal saline is the best. Because if you do the dextrose, it will cause burning of the tissues. It can cause a lot of problems. So don't do. If you are going per IV, then the recommended one is dextrose containing. For the IM, based on the age of the patient, whether a child or an adult, you have to prepare different concentrations. IV IM quinine. Dose is also the same. As I said, for all routes, quinine, same dose, same cutoff point of 600 milligrams. For adults, it is recommended that for IM quinine, you dilute the preparation to a concentration of 100 milligram per ml. Whilst for pedics, your target is 50 milligram per ml. Your starting stock solution, 2 mils containing 600 milligram quinine. That is the strength of quinine injection. 2 mils in an ampoule containing 600 milligrams of the active ingredient. And your target is to prepare and administer per IM a diluted solution that contains 100 milligram per each mil for adults. And for pedics, 50 milligram per each mil. Always dilute, else hypotension will occur. And therefore, that is why we are diluting the thing. We are not injecting the stock solution of 2 mils containing 600 milligrams. So, class captain, are you there? Class captain.
Yes, doc.
Yes. So, if you are dealing with an adult patient, and the adult patient comes, you are to give IM quinine. Your starting material, the ampoule there, is 2 mil containing 600 milligrams. You are to dilute this one such that at the end of the day, you are getting a milligram for adult IM administration around to get a final volume that contains.
Your network
Hello?
is breaking.
Oh, sorry.
We stopped hearing you from when you said 2 mil that contains 600 milligram of quinine.
Okay. So can you hear me now?
Yes, please.
Okay. So I'm saying that for adults, the targeted dilution or the concentration is 100 milligram per mil to be prepared. I'm looking at IM. As for IV, we are done. And for pedics, it is 50 milligram per mil. And your starting material will always be 600 milligram in 2 mil, the quinine ampoule that will be given to you. So I'm asking, class captain, if you are dealing with a 70 kg man who needs IM quinine, you have been given 2 vials or 2 ampoules or thousands of ampoules available. Each of them 2 mils containing 600 milligrams. Your patient weighs 70 kg, and you are to dilute so that for an adult patient, you will have 100 milligrams per mil. How are you going to play around with this, considering the patient weight, the dose, and everything? So what will be your approach? 70 kg man needs IM quinine. You have been given 1,000 ampoules. Each one is 2 mils containing 600 milligrams of quinine HCl, quinine sulfate. How do you go around this?
Okay, so first off is to find out how many milligram of quinine does the patient need, and since we are doing 10 milligram per kg, so the patient needs like 700 milligram of quinine, right? And then our ampoule contains 2 mil. 2 mil contains 600 milligram. So we'll be needing 2 ampoules. No. Yes, we'll be needing at least 2 ampoules to be able to get.
Captain.
Doc.
Vice Captain. You have forgotten the maximum dose that you can give. I intentionally did that.
So that we just we don't go past 600 milligrams. Sorry, we will not go past 600 milligrams.
Okay, continue.
So we will just need 1 ampoule because we can't go past what's it called? We can't go past 600 milligram. And then for adults, we know that we give 100 milligram per mil. Right. So, what's the question again?
The question is, you want to dilute the stock solution, your starting solution, so that we can get a final volume, which each mil will contain 100 milligrams. That is what we can give per IM to the adult patient. So that's your 2 mil containing 600 milligrams. How do we dilute it to what volume? So that each mil of that final diluted solution will contain 100 milligrams. That is what is recommended.
You have to dilute it to 6 mil.
6 mils, which means...
By adding 4 mil of water, sterile water or the normal saline.
Perfect. So this is very simple. You are starting with 6 milligrams in 2 mils, and you are to get a final diluted solution, of which each 1 mil will contain 100 milligrams. So with a 2 mil containing 600, you only add your diluent to it, so that you are going to get 600 over 6. 600 over 6. So you add 4 mils, as she said, to the existing 2 mil containing 600 milligrams. So the volume alone will increase. The active ingredient will remain at 600 milligrams. So you are shooting the volume from 2 mils to 6 mils by adding 4 mils to it. And the final volume will now be 6 mils, still containing 600 milligram quinine. And if you have to break it down, it means each mil will now contain 100 milligrams. This is what you are supposed to do. But there are still some advice or recommendations that you need to give to the one giving the injection. For an adult patient, if per the weight, the required dose, and therefore which will have an effect on the final volume to be given. For example, in this patient that we got 600 milligrams as the cutoff point, it means we are going to give all the 6 mils diluted solution. And the recommendation is that if you have an adult patient in whom the volume to be administered, that 100 milligram per mil solution, the final volume or the total volume to be administered is more than 5 mils, Don't administer all the 5 mils, or as in all the volume that is more than 5 mils. Here, we are doing 6 mils as an example. Do not administer all the 6 mils at one site. Once the volume is more than 5 mils, do not administer all at one site. Divide the volume into 2 and inject into 2 separate IM sites. So, for example, in this patient that requires 600 milligram as a dose, it means we are going to introduce all the 6 mils. And since it is more than 5 mils, we are dividing the 6 into 2. We are going to get 3 mils, 3 mils. Inject each of them to separate sites at the same time. So if you are choosing, let's say, your anterolateral thigh or your buttocks, left buttocks, right buttocks, each of them will pick 3 mils, 3 mils, meaning you have introduced 300 milligrams into each. But to the patient, you have delivered a total of 600 milligrams as a dose. Repeat this every 8 hours for a total of 7 days. That is, if the patient is unable to tolerate orals all through. If after the first day, the patient is able to tolerate the orals, you can switch to the oral quinine at same dose, same cutoff maximum dose, at same frequency to complete the 7-day course. I repeat, if after the first day, 24 hours, meaning you also give 3 doses, the patient gets better on quinine and can now tolerate orals, switch to the oral quinine. As for quinine, be it IV, IM, oral, the dosage regimen is the same, 10 milligram per kilogram body weight, maximum 600 milligram, 8 hourly for 7 days. But since you have given some for the first day, you are only going to continue to complete a total duration of 7 days. Don't do the orals for a whole 7 days. In addition to the injections, that will be 8 days, which will be wrong. You are continuing to complete a total duration of 7 days. How about PDIX? Class captain. PDIX, we said we are going to prepare 50 milligram per ml. As for adults, we have it. So how do we manipulate? Same starting material, 2 mils containing 300 and 600 milligram quinine. How do we manipulate this? Get a diluted solution of which each mil will contain 50 milligram per mil. How do we go about this one? Class captain.
Is it same weight?
Oh, no. A PDX cannot have a weight of a normal PDX of 70, no. So let's use something that is reasonable, say 20 kg. And please mind you, the dilution has nothing to do with the dose. The dilution doesn't have anything to do with the weight or the dose. The dilution is just a recommendation. It's on the recommendation that for PDX, prepare 50 milligram per ml. For adult, prepare 100 milligram per ml. After this, then you come and think about the dose based on the weight. So even if you don't know the patient to give and you are asked to dilute, you just ask for the age, just to know whether it's an adult or a child. And that will let you know the targeted concentration you are to prepare. Adult 100 milligram per ml, PDX. Then you look out for the weight for the dose. And that will help you to know how much to give, how much of the diluted solution to give, and whether you are giving it at one site or dividing it into 2 and give it concurrently or simultaneously. That's a better way. So, class captain, how do we go about PDX? 50 milligram per ml is our target.
So I wanted to ask, the dose, is it still 10 milligram per ml, sir?
Still, for all
10
age
milligram per
groups,
kg, sir.
yes, for all sex, all age groups, everything, all route of administration, quinine is the same.
So the child would need 200 milligram of quinine, and then so it'll be 200 divided by 50. So that's 4 mils. But
No, so I
we
want you to
have
prepare the
to.
diluted solution first, class captain. You are to prepare this time 50 milligram per mil diluted solution. You are not using the same adult concentration. The adult concentration was 100 milligram per mil. In pedics, it is 50 milligram per mil. So I want you to demonstrate how you dilute the 2 mil containing 600 milligram to get 50 milligram per mil. But please, can you see my slides? Hello?
Yes, we can see your slides.
Hello?
Hello, we can
So
see
class
your
captain,
slides.
I think I've even, so can you see the current one, the current slide?
Yes.
So what are you seeing and how do you explain it?
If we have if what we have, the ample we have is 2 mils, and it contains 600 milligrams of quinine, and we have a child that needs 200 milligram, we would have to take out at least 0.
Class captain, you are still not getting the fact. Before we get to the dose, even without any information on the dose, once we know that we are dealing with a pediatric patient, what comes into mind is we are going to prepare or dilute the existing quinine to a strength of 50 milligram per mil. So that is our first task. Before we even consider the dose and how much to give. Are you okay? So now you've been given 2 mil ampoule of quinine containing 600 milligram. For a pediatric patient, you are to prepare a diluted solution which has a strength of 50 milligram per mil. Let us know how you go about it first before we consider the actual dose calculation and how to administer it. Let somebody help us. Who are in class? Yeah.
Yeah, so the 2 mil ampoule contains 600 milligram of quinine. And for a child, you want to prepare half the concentration, as in you need 50 milligram per mil concentration. So with your 5 mil, as in with your 10 mil syringe, you draw 5 mils of either sterile water or normal saline for injection. Then you take 1 mil of your quinine solution. If the 2 mil contains 600, then you're expecting your 1 mil to give you 300 milligram of quinine. And that's going to give you a concentration of 300 milligram of quinine in 6 mil of volume. And the concentration there is going to be 50 milligram per 1 mil. And per the child's weight you give, you said the child's weight is 20.
Let's pause here and ask whether everybody is okay. Let's pause here, then you continue. So are we okay with the explanation given? Class captain, are we okay? So he said, since the stock contains 2 mils contains 600, he is picking half, which is 1 mil, into a syringe, and that will contain 300 milligrams. So in the syringe, we will have 1 mil containing 300 milligrams. How do we manipulate this so that we will get a final volume of which each ml will contain 50. He said he's going to add 5 ml of sterile water to this to increase the volume to 6 ml, still containing the 300 milligram. And if you divide through by 6, you are going to get 50 over 1, which is 50 milligram divided by 1 ml. And that is what we want to get. Class captain, are you okay? Hello? Is everybody okay? If you don't understand, please unmute and let us know so that he goes over. Okay, please continue. So then, how do we get the volume that contains the required dose? And the advice here is that for PDIX, if per the weight, the required volume of the diluted solution will be more than 3 ml, divide into 2 and give it simultaneously into separate sites. I repeat, for PDIX, if per the weight, the required dose as compared to the diluted solution prepared will be more than 3 ml, divide that volume of the diluted solution containing the required dose into 2, once it is more than 3 ml, and inject into separate IM sites simultaneously. So please continue from there. So now we have our diluted solution. Continue.
You mentioned that the child weighs 20 kilogram, and the dose for quinine for administration is 10 milligram per kilogram body weight. So the child's weight 20 times the 10 is going to give us a required dose of 200 milligram. And from our prepared solution, we know that every 1 ml contains 50 milligrams. So the child requiring 200 milligram will need 4 ml of quinine solution. And since that volume is greater than 3 ml, then you divide it into 2 and inject 2 ml into each tie.
Perfect. That is perfect, 100%. Class captain, please, are we okay? Thank you very much, sir. 100% explanation. 100%. It doesn't need any modification. I'll just stick to that. Class captain, are we okay? And can we continue? Class captain, are you there? Anybody with any issues with this dilution of quinine for IM administration? All right. So key things from quinine. Quinine should never be given undiluted because it can cause hypotension. IV quinine, it is okay to use a dextrose-containing agent since you are going straight into the bloodstream. There will be no issues with muscle injury. But for IM, dare not give any diluent containing dextrose because dextrose can burn muscles and cause injury. For IM, we have separate concentration for adults, different from that for PDIX. Adults, 100 milligram per ml to be prepared. PDIX, 50 milligram per ml to be prepared. For adults, if per the dose needed, the amount of diluted quinine solution will be more than 5 ml. Divide the total volume into 2 and inject separately, but simultaneously into separate sites. For PDIX, 3. If it is more than 3, divide into 2 and do same. The dose for IM, IV, orals, cutoff point is the same for all age groups, all sex, whether you are pregnant or not. It's always 10 milligram per kg, 8 hourly. Maximum dose, 600 milligram for a total of 7 days. If you give your first daily dose, which is the 600 milligram cutoff point, you can switch to oral quinine only to add onto the first day to complete a total of 7-day course. Are we okay? Class captain, I want to hear from you. What is the time?
Oh, it's 11:37.
Okay. So quickly, since severe malaria can cause some complications, it is very important that we look at those complications. For example, the hyperpyrexia, the severe anemia, if it becomes cerebral malaria, even convulsions and all those things. All these are considered as supportive care. The main care is the elimination of the parasite, which we have done justice to it. Be it whatever drug that you are using, you've done justice to all the possible agents. There are different routes of administrations, dilutions, and whatever. Now let's look at supportive care. Class captain, let me know when it's 12 so that we can close. So one of the problems is hyperpyrexia. It's an infection and therefore your system will react. So in this case, you have very severe, very high body temperature in the region of the 38.3s and 39, at times even 40. So the recommended agent in all age groups, first line is paracetamol. And nowadays we have paracetamol IV. You have paracetamol IV, so very good agent. So you can use a dose of 15 milligram per kilogram body weight. 4 hours, normally you do 6 hours to 8 hours. So 8 hourly, 6 hourly. So this can be used. In pediatrics, you can add strategies like tepid sponging, non-pharmacological strategies like tepid sponging, fanning the baby and those things. So even in adults, you can apply. But in adults, normally, the paracetamol is okay. So that is how you manage with continuous monitoring to know. Of course, once you are able to reduce the parasite load, it normally goes down. It correlates with a reduction in the fever. So reducing parasite load always correlates with a reduction in fever. If you give your drugs and still the temperature is still high up there, that could be an indication of treatment failure. Therefore, you have to do it. Then somebody to those who can suffer from coma, cerebral issues. So in these individuals in coma, of course, they don't keep their reflexes, the airway reflexes, and therefore are at increased risk of issues like aspiration. So to prevent aspiration, then you need to secure the airways. How do you do it? You intubate. So those who have been to, all of you, of course, you've done both tertiary and peripheral. Class captain, that's what you do, right? You've done your peripheral hospital practice. Some of you have switched now. Others are going to the teaching hospitals, and those who were there are going to the peripheral hospital. Is that not so?
Yes, please.
It's because I'm hitting on intubation. So if you are not familiar with intubation, those who did the peripheral yet, that's in first, you go to the teaching hospital, you do presentations on intubation. Typical is the rapid sequence intubation. There are indications for intubation. One of them is comatose. If you tip into coma, you cannot coordinate, you are off, and therefore issues like aspiration can occur. Another indication is respiratory compromise. There are so many indications for intubation. So when you get coma, for example, you need to maintain and secure the airways. One critical technique is to intubate and make sure that the patient doesn't aspirate. If the patient has issues with respiration, you intubate and connect the patient to a ventilator for that machine to do the work of the respiration. You do that. This goes with other care. Intubation always goes with analgesia and sedation to ensure patient comfort. If it gets to your turn, if it happens that you visit the emergency or the critical care unit, you'll be taken through some of these topics. In general, one of you will present on rapid sequence intubation, how it is done and all those things. So you do that. Or if the patient doesn't demand, if the patient doesn't qualify for intubation, which means the patient is better, to avoid aspiration, you keep the patient on his or her side, so that if the patient is aspirating, it cannot pass through the airways and to the patient. Of course, such comas normally comes with complex infections. And for all you know, there are other possible infections in addition to the malaria. So stubborn infectious agents like Pseudomonas and what have you, even causing issues like bacterial